So welcome everyone for this wonderful event organized by I3 initiative with the idea to make very popular and worldwide the IVF knowledge and be able to share a lot of very nice presentation with very good speakers worldwide with the opportunity of the webinars, which give us access to everyone to all these activities. I'm sorry that I'm Spanish, so like Celia Cruz say, my Spanish is not very good looking, but I will do my best to introduce this webinar and introduce one of our moderators, which is Ahlström. Probably have done wrong also your name, so sorry about that. And also Jullin Fjeldstad is again another very complicated surname, is with us, is with me joining and doing the presentation of this webinar. In the case of Aislinn, well, I know very well Aislinn. She's a very good scientist. Is actually the scientific director of Livio clinics in the Nordic countries. Actually, we are working together in the same group of clinics, so it's a great opportunity for us to share experience and knowledge. I didn't know that she was from Australia. Actually, I thought that she was from Sweden, but I guess that you have both nationalities. And well, now the floor is yours, and thank you for joining I3.
Yeah. Well, thank you for the nice introduction, Marcus. It's good to be on from the same group these days. Just to reciprocate, Marcus is the Global Director of Embryology Research. I think everyone's read multiple papers from his research group. He's also a senior embryologist in the IVF unit at Valencia. He has a number of awards, received and nominated twice for a prize paper in ASRM. And I think, you could look at his CV or impressive bio online on the I3 website if you want to delve more into the number of publications. And as Marcus mentioned, we're also joined by Jullin Fjeldstad. She's the head of the clinical embryology and scientific operations for Future Fertility. You've probably seen her in these sessions before. And she works closely with partnering clinics to ensure smooth onboarding. And additionally, she oversees Future Fertility's scientific project collaborations, bringing research findings to international fertility conferences, just like this one. Welcome.
Thank you so much, Aisling. It's a pleasure to be here with such great people in the field, and I'm happy to be here this evening with you. What promises to be a really enlightening webinar. Please note for attendees, please post your questions in the Q&A section and not in the chat function for the question period so that we can, as moderators, directly answer your questions. Our first speaker I would like to introduce is Dr. Xavier Pollet-Villard, and I apologize, I also am not very good at French, even though I'm Canadian. He is an MD as well as has his MSc. He is head of the Net Assisted Reproductive Technologies and Andrology Center, located within the Pôle Santé Orléans, Saran, France. He's very passionate about reproductive medicine, and his work has been focused on improving the cumulative live birth rate by participating in the development of tools and guidelines designed to help IVF practitioners, offering the best outcomes to their patients. He's going to speak to us today on short inseminations, and I'm really excited to listen to what he has to tell us.
Thank you very much, Jullin, for this nice introduction. Thank you very much, I3 and Giles, for inviting me to talk about short insemination, great outcomes. Maybe, let's see. So, oopsie. So let's go for the disclosure. Okay. So now the context. So we know that our beloved oocyte is also the most sensitive stage during IVF to chemical or physical stress. And I don't know if you read it, but I do read it. This is a little a graphic from Garner Edwell from a recent book that shows that all the stress that we could do in the lab and that all this stressor could induce cumulative stress and decrease oocyte viability. And I added very humbly the fact that maybe also our fertilization protocol could induce stress and the loss of oocyte viability. So when we talk about ICSI optimization, there has been a lot of study published about semen preparation, especially centrifugation-free semen preparation, but also spermatozoa selection that could improve ICSI outcome. And also recently, we've seen publication about the use of media without deuterium, the use of media with antioxidant, and also the ICSI technique per se could improve or decrease the outcome depending of the cases. We have seen a lot of studies about piezo, oocyte activation, artificial oocyte activation and automation, and also the timing has been shown to be important. However, ICSI is an invasive technique and caution should apply when we use it for non-male factor infertility. So what about classical IVF improvement? So I will talk about a very recent meta-analysis that compared short insemination, i.e. 1 to 3 hour co-incubation with spermatozoa versus overnight insemination for classical IVF. So in this meta-analysis, studies were collected, and these studies may have used early rinsing and denudation in the next morning, or early cumulus cell removal, which I will call denudation in the following slides. So the most important outcome is that, first of all, you have the similar live birth rate between short and overnight co-incubation, but also the same polyspermy rate. However, when you are using short insem, this meta-analysis shown that you have higher ongoing pregnancy rates, but also a higher top quality embryo rate. So, which means that, which implies that maybe the oocyte quality is better, at least maybe less damaged when you use short insemination compared to overnight. However, there is a drawback. Whatever the technique, early denudation or only rinsing, you have a lower normal fertilization rate when you use short insem compared to overnight insem. And very recently, there was also a study that shown that short insemination, i.e. in that case, 2 hours co-incubation with the spermatozoa, followed by denudation the other morning, showed an improvement in embryo morphokinetics, and that could be linked to a lower malondialdehyde content in the insemination drop. And in that study, even though it was not significant, there was a trend towards better embryo quality and clinical outcome for short insemination. So that's what we know right now. And that is something that I didn't know when I start doing short instem. I started in 2018 when I opened a new lab. And at that time, I decided to do short insemination with early cumulus cell removal, early denudation, because I had a previous good experience with early rinsing in some labs, IVF labs in Paris. And we had shown an improvement of embryo quality with early rinsing, especially in poor embryo development patient, but also advanced maternal age patient. And I also read that book, Principle of IVF Laboratory Practice, that was issued in 2017. And you have 2 very good chapters about classical IVF and short insem by McCaffrey and Karaguga in this book. And they have this experience with short insem and early cumulus cell removal. That seemed really nice. And for me, it was the next logical step after having done a lot of early rinsing. It was the next logical step when I decided to design a full time-lapse laboratory, because we will see it after, but it gives you a lot of flexibility in classical IVF when you are full time-lapse. So what has been our protocol since 2018? First of all, when we do the follicular screening, we do a reasonable COCs trimming to remove blood clots or dark walls on the cumulus. And then we culture COCs in 100 microliter drops under oil in fertilization media with 1 to 3 COCs per drop. But when possible, we practically always do 1 or 2 COCs per drop to avoid glucose depletion. Then at 39 hours post-trigger, we co-incubate with spermatozoa that have been prepared with density gradient centrifugation. To be able to do it correctly, we trigger the classical IVF cycles first, and we also program them first in the OR in the morning. So we inseminate at a concentration of 100,000 motile progressive spermatozoa in 100 microliter drops. And our cutoff to decide if we do classical IVF or ICSI is to have after gradient more than 5 million per mil spermatozoa in concentration and over 80% motility. And we inseminate 1 to 3 COCs per microdrop, but most of the time, for the reason evoked earlier, 1 or 2. Then 4 to 6 hours after insemination, we denude the COCs with a 145 micron diameter tip. So we are between 43 and 45 hour per trigger. So it's between 3 p.m. and 5 p.m. And first, before denudation, we look at the cumulus cells, and if they are not dispersed enough, we can sever the oocytes from the cumulus mass and put it for 1 more hour in a drop with spermatozoa, 1 more additional hour. So most of the time, it will be completely dispersed, and we can do the denudation. And sometimes we discuss cumulus use, but actually we have never used cumulus. We never had to if we had very dense or sticky cumulus. So then we rinse in culture media, and we directly culture in the time-lapse incubator. And since June 2024, we decide if we do early rescue ICSI after 6 hours post-insemination in the absence of second polar body extrusion for more than 70% of the mature oocytes of the cohort, and sometimes also it's decided by the embryologist. So this little video is to show you how it looks like most of the time. So you see that the cumuli are well dispersed for all the drops. This was actually a case from yesterday, and I will elaborate on this case. So with 290 micron tip, I'm taking the COCs and putting them in the rinsing drop before denudation. See? Okay, so now this is denudation, the denudation with 145 micron tips. So you see it is easy. I think I did only 10 back and forth with the tip. So it's really easy. And then I put it in a clean rinsing drop. Okay, so what have been our outcomes? So we did a total of 232 cycles. The mean age for the patient were 32 years old, so very young. The number of COCs was 2,861. Mean number of COCs per aspiration, 12. Total number of mature oocyte, 2,466. So the maturity rate at denudation in this unselected population was 86%. And this is our fertilization rate. So I have 2 ways to present you the fertilization rate. The 2PN rate per meta2 at denudation, so it's 73%. The 1PN rate is 4.87%, let's say 5%, and the polyploidy rate is a little high, 7.66%. So I decided to compare our outcome to the Vienna Consensus competency and benchmark values. So I took the Vienna Consensus reference population, and you know, in this consensus, they compare the fertilization rate. The denominator is the number of COCs. So the 2PN rate per COCs in the reference population is 63%, which is a little bit over the consensus competency. Remember, it's short INSEM with early denudation. The 1 PN rate per COCs is 4%, and the polyploidy rate is 6.34%. So a little bit higher than what is recommended. The total fertilization failure rate, so no 2PN per COCs, is 1.9%. And the day 5 blastulation rate was a little bit more than 58%. The good to top blastocyst quality rate per zygote, 2PN zygote, was 44%, which represent a proportion of 75.66%. So we are pretty happy with the culture outcome, but we are not really happy with the fertilization outcome when it comes to Vienna consensus indicators. However, when you look at the 2PN rate per mature oocyte, it's kind of good. We have the same thing in a non-selected population for ICSI. So we think it's kind of normal in our population, in our lab. So the cumulative live birth rate per intended oocyte pickup was in the reference population 44%, a little bit more than 54%. And if I look only at the cumulative live birth rate per oocyte pickup with at least one embryo transfer, it goes up to 61%. And the mean number of embryo transfer to live birth was 1.73. So this is a real population. There is no exclusion about this population. In France, the we cannot do PGS, so we cannot test 3PN blastocyst. So that's an issue, I think. And I decided tonight to compare this outcome to a publication that's actually used practically the same protocol that we do. So this is an Asian publication. So in this publication, they compared early cumulus cell removal group, short INSEM with early cumulus cell removal at 6 hours of co-incubation with overnight insemination. So the difference between these teaming hours is the fact that they inseminate a lot more motile spermatozoa per COCs. They use cleavage stage culture and transfer. We do blastocyst. And this was a selected population. They excluded patients with uterine or tubal conditions. So what they found is an outstanding normal fertilization rate. The denominator is the COC, the number of COCs. So they had 72% normal fertilization rate in the early cumulus cell removal. But this was significantly lower than their overnight insemination. Their polyspermia rate, however, is higher than ours. And this is, I think this is no surprise because they are inseminating a lot more of spermatozoa. So what is interesting in this study? So in this study, they compared retrospectively with propensity score matching early cumulus cell removal to overnight insemination. And what they found is that even though there was a significantly higher fertilization rate in the overnight arm, there was a significantly higher cumulative live birth rate in the short INSEM and early denudation arm. The neonatal outcomes were very similar and safe between the two groups. So this study, I think, is really important because it shows that short INSEM with early cumulus cell removal is not only safe, but it provides you with a higher cumulative live birth rate than overnight. So when you do early cumulus cell removal, of course, the next step is to say, okay, and if I have total fertilization failure or partial fertilization failure, maybe I could do early rescue ICSI. So the first question is, when should I do early rescue ICSI? So what we know from the literature is that around 80% of fertilized oocytes have already extruded their second polar body at around 4 hours post-insemination. The issue is that sometimes it is hard to say if it's a fragmented first polar body. It can be also hard to see the second polar body even with time lapse. So whatever, the earlier you inject PB1 oocyte, the higher the free PN rate. So what can we do about it? In our experience, you can see between 4 and 6 hours post-insemination, you can see fertilization sign. So the first one is the extrusion of the second polar body, which can be tricky. Very seldom, in very seldom case, you can see a fertilization cone. But most of the time, what we see are cytoplasmic waves and movement of the plasma membrane. So these are little tricks that can tell you if the oocyte is fertilized or not, irrespective of the presence of the second polar body. So this little video, how early can you guess? How early would you be confident to inject? Okay, another time, look, you have clearly movement of the membrane plasmic. You can see cytoplasmic waves in this oocyte. However, if you look at the polar bodies, it's really difficult to tell if there are two polar bodies or if this is a fragmented first polar body. So now early rescue ICSI, is it safe? We know that short insem with early cumulus cell removal is safe, but what about short ICSI? I chose to present two studies. The first one is a large study from FANG, and this team showed that there was only a slightly decreased high-quality embryo rate in early rescue ICSI oocyte compared to IVF-derived oocyte or IVF plus short insem and early denudation oocyte, or classical ICSI oocyte, which means injection between 40 and 42 hours post-trigger. So it looks safe from an embryology perspective. From a clinical perspective, the outcomes were quite similar between all these study groups. And from a neonatal perspective, another study from Jiang, very recent study, showed that actually neonatal outcomes are really reassuring. So you don't have a significant difference in terms of preterm birth, large birth rate, low birth rate, or macrosomia. So it is pretty safe, even though in this study there was also a significantly lower birth rate compared to conventional ICSI with early rescue ICSI. So the take-home messages for short incubation and early denudation. What does it provide in the lab? First of all, it enables standardization of culture dish preparation the day before oocyte pickup, irrespective of the fertilization technique. Then, and I think it's important, it enables a quite real comparison with ICSI fertilization rate. So you don't need to compare 2PN to number of cocks. As an indicator, you can use the maturity of the oocyte. Also, if you use time-lapse, there is no risk of missing any pronuclei because of early PN fading. Now, this thing, I think it is my opinion, it is inferred from a very recent article. I think there may be potentially less bacterial contamination of culture media when you do short insem with early cumulus cell removal, because you shorten the length, the duration of COC culture, and then you also give less room for bacteria to grow on this good matrix. Go back. What we can say also, it seems that you have increased clinical outcome despite decreased fertilization rate compared to overnight co-incubation. And it is quite safe regarding neonatal outcomes. Now, what are the perspectives? I think we need to better understand and prevent the formation of 3PN and 1PN embryos in classical IVF. There are many ways we could do that. We could screen for phospholipase zeta activity. We could screen maybe for oocyte defect. We could maybe adapt the technique because there are many different techniques for classical IVF. We could also do molecular genetic fertilization check for 1PN and 3PN to be able to detect the ones that are actually euploid. And the safety of course, it enables early rescue ICSI, and early rescue ICSI seems safe in recent trials that assessed neonatal and clinical outcomes. So I think, this is my opinion, that routine use of early rescue ICSI is worth considering in 2024, which was not when I started to do short insem and early denudation. So also, and the biggest advantage lies here, is that you don't need to fear anymore partial fertilization failure or total fertilization failure. And so maybe we are going to be able to promote classical IVF. And maybe also use decreased cutoff for classical IVF indications. So can we make an omelette without breaking some eggs? That is the question. This is the case you've seen the video from the denudation. This was yesterday's case. So it was a very young patient, 26-year-old. She had endometriosis, stage 3 and 4, and the male counterpart had asthenospermia. Actually, we planned to do an ICSI, but we decided to do a classical IVF because we were very close to the cutoff that we chose, 5 million per mil and over 80% motile progressive. So we had 21 COCs, 21 mature oocyte at denudation, around 4 hours post-insemination. And we got from this case, I'm going to fast forward, we got 18 2PN, 2 3PN, so a little bit high rate of polyploidy, and only 1PN. What was interesting in that case is the fact that we had very interesting oocyte that started. Okay, let's stop around 7 hours. Here you can see the first pronuclei and the second one. And we are at 7.6 hours. But if you go at 12 hours and then 16, 18 hours, you have only one more pronuclei. So the good thing also with time-lapse is that you are really able to look at these kind of events and know that this embryo was probably actually fertilized correctly, and that the 1PN that you see at 18 hours is actually the results of the fusion of the pronuclei. So thank you very much for your attention.
Thank you very much, Xavier. I was trying to connect the audio. Thank you very much for your very nice presentation. You really have done a very nice review. I'm thinking very local that you should come to Spain and make a tour of your lecture everywhere, because here we're doing almost 100% ICSI. And the embryologists, we love to do more IVF, but unfortunately we can't. Even that is not in our hands to take the decision to do IVF, that we are pushed by the doctors or by the situation. A very simple question, a couple of very short questions. Which frequency do you have of IVF in your clinic? I mean, you are one researcher in IVF. I mean, which is the proportion? I'm just wondering, how often do you do IVF?
It's quite low, actually. It's around 10%. It's around 10%. Okay. We do a lot of ICSI. I won't be the one telling you that doing 100% ICSI is bad. I have a lot of doubts. I do it only because of caution, because I think, first of all, that the embryos look so nice with this technique. And there are many labs that I converted that don't want to go back actually to overnight co-incubation, because they see the embryo, they say, oh, the embryo looks better. We have an incredible blastocyst rate. Sometimes you have issues. And of course, sometimes you would regret not having done the ICSI. If you have too many free PNs, maybe because you have an oocyte defect, maybe because you have a spermatozoa defect, you have too many free PNs, you cannot do anything. So that's the issue. So I have doubt about this. I don't think it's a mistake to do a lot of ICSIs. I do a lot of ICSIs, maybe because my patients also require it. But you talked about the gynecologist deciding the techniques. I actually thought the patient that I presented, the 26-year-old gynecologist, and we said, okay, ICSI, because the diagnostic sperm analysis was really bad. So the guy was put on antioxidant, many things were done to improve the sperm. And the decision was taken, and I called the gynecologist, and she laughed about it. We laughed about it, and I said, okay, I'm going to do classical IVF. Just cross your fingers that we don't have too many free PNs. And I think this patient is going to have a lot of blastocyst, and that we took the right decision. But I cannot be sure, I cannot be certain that ICSI could have been better. It is really tricky to compare. So we plan to compare with propensity score matching, with case over ICSI cases for non-male factor to see if there is a difference. But there are no mistakes. There are only you just can do what you do with what you have in your situation.
Definitely. There's a lot of questions in the audience that we will do later. So thank you, Xavier, for this very nice presentation. And later we will have a discussion. And well, I forgot to say at the beginning that this webinar is sponsored by Future Fertility. So thank you very much, Future Fertility, to this very nice activity. So now we move to the next speaker. I would like to underline that today in this session, one moderator, which is myself, and two speakers are from Valencia. Valencia is one very nice city in the Mediterranean Sea, in which we have probably most of the best embryologists in the world, at least scientifically talking. And then our next speaker, I'm very happy to introduce him, and I don't need to read his experience or his CV, because he's a very good friend. Also, he was one of my PhD students. He did a very nice research on the embryoscope many years ago, especially in the embryo respiration, oocyte respiration. And he's one of our senior embryologists in Valencia. He's also teaching in our master's degree in the university. He's also doing most of the important work in our PGTA program. And he do also a lot of training activities, especially from embryologists worldwide. So he's very well-known, good trainer like embryologist. And Alberto, today also from Valencia. We are not in the same location, but we're in the same city now. He's going to make us a presentation about the experience using calcium ionophorus, how to improve the fertilization rates.
Thank you, of course, for inviting me. Despite the light hour here in Spain, it's a pleasure to be here and to share with you this our experience with this oocyte activation. So we try to demonstrate if with this oocyte activation we can improve the fertilization and the usable blastocyst rates. So I don't have any interest to declare with this lecture, of course. And as you know, there's a small number of cases, 1-3% of the treatments cycles, where we get a fertilization failure or levels of fertilization lower than we expected. So sometimes it's because we use just a small number of the oocytes, just one oocyte, two oocytes. But sometimes happen this fertilization failure or low fertilization levels in patients with a good number of oocytes. So the main reason of this failure is the lack of oocyte activation after injecting the oocytes. And then we don't know if the problem is the oocyte or the sperm, and when the problem is this oocyte, so maybe it's because we have a cytoplasmatic immaturity due to inadequate protein synthesis or deficiency in immune pathways, or even disorders in the spinal. But when the problem is the spur, we can use this oocyte activation. And the problem usually, when the problem is the spur, is because of alteration in some proteins, especially in one protein, in the expression of this protein, a phospholipase zeta. The less common is the problem is include failed spur head decondensation, premature spur chromatin condensation, or chromatin packaging impair or DNA damage. You know that we have 6 major steps that's very important in vivo and in vitro fertilization. All of them are important. We know that this oocyte activation is mandatory, okay, for the embryo development and the embryogenesis. Why? Because this oocyte activation implies a different events and transform one oocyte arrested in metaphase 2 into an oocyte properly fertilized and starting the embryogenesis process. This is what happens when everything is fine and when the spur binds to the oocyte membranes, and this spur realizes this phospholipase zeta, and this protein hydrolyzes the PAP2 into DAG and IP3. This DAG is not soluble in the cytoplasm, but this IP3, the inositol triphosphate, is soluble and join or binds to these IP3 receptors in the endoplasmic reticulum, and then the calcium release and oscillation happen. And this increasing the calcium oscillation, so causing the activity loss of MPF, or the maturity promoter factor, and finally finishes the meiosis and restart the cellular cycle. The activation happens in the cell cycle resorption, and we see destruction of the second polar body, formation of PN, and the exocytosis of the cortical granules. And then this is a paper demonstrate that this when was published, this paper, and was in a mouse, and they demonstrated that when they inject the spur just in the point 0, just in that moment, we can see an increase of this calcium level, okay, and after that we can see a second large calcium spike or rise within 10 or 15 minutes, okay, and after finally we see a different calcium area of calcium increasing oscillation. So when this oocyte activation doesn't happen naturally, we need a chemical activation. We need to do it with a chemical activation with different substances. And from all of them, we know that, because it's published, that the calcium ionophore is the best because it's less toxic or detrimental for the oocytes. And the indication we can use when the fertilization fails, and a low fertilization rate, less than 30%, in very severe male factor, or even in cases when the embryo development is arrested and when we observe a poor quality. And then see, the way to do it is very simple. After injecting the oocytes, we expose to the calcium ionophore, to the slide where we prepare these dilutions with this ionophore, calcium ionophore, for 15 minutes. And remember that I told you before, so within 10 and 15 minutes, we observe this rise or increase of these levels of calcium that are mandatory. So this is the reason that we expose the oocytes for 15 minutes. And this is the first study that we performed in our clinic with this number of patients, 66, they came to our clinic. We performed the different analysis tests. Everything was normal, the sperm, the hormones. And then we offered the conventional ICSI. And we saw that the cancellation rate was very high because we got a lower level of fertilization that we expected, less than 30%, or a total failure of fertilization. After that, with the same patients, in the next attempt, in the new attempt, we offered this activation, and we saw that the cancellation rate was very, very low. So when we take a look in depth, we have seen that the cancellation rates in the conventional ICSI in the first attempt was very, very high, almost 70%. After that, with the activation, cancellation rate was 23%, and the fertilization rates we passed from 13% to 51%. Ongoing pregnancy rate with a conventional 21 and 47 with this activation. The implantation rates 13 compared to 31, and the percentage of cycles with surplus embryos. So with a conventional ICSI, as we got a lower level of fertilization, we didn't have a lot of embryos, and finally we just could freeze just this percentage of embryos in the same cycle, and with activation we increased to 70%. And in this table, you can see that's the effect of the weight of this application of the artificial oocyte activation compared to when we don't offer this, we don't apply this activation. So we didn't see any differences, okay, when we apply this activation or conventional ICSI according to the day of the transfer of maternal age. But when we have checked this weight of this activation, after applying this activation, and we check the effect on ongoing pregnancy per cycle of the transfer, we have said that we could increase in 4.5 times more the probability of the chances to get an ongoing pregnancy per cycle. Not per transfer, we didn't see any differences, because once we reached to the embryo transfer, it's logic that we didn't see any differences. So as we can increase the percentage of fertilization, we got more embryos, and then we increase the chances for the patient. But once we arrive to the moment of the embryo transfer, so we cannot increase, okay, the chances of the presence. So once the embryos were available, obviously we cannot increase the chances. And in this table, you can see that the live birth rates was in the conventional ICSI 7% compared to 20%. And we wanted to check so the neonatal outcome, because you can find in the literature that some articles that they question that if it's a safe process or technique or not when we use this activation. So in our case, we didn't see any differences according to the malformation, or the major or minor malformation, or Aguilar, or the low birth weights between two groups. In the same line, Thomas Hermer published this paper. So they compare the same in the previous cycles. Okay, they got these results, a low results. Fertilization rate was lower, and the blastocyst formation and implantation of clinical pregnancy rates. And after that, they used this activation for the cases in several manufacturers. And they saw that when they apply this activation, they could increase these levels of blastocyst formation, fertilization, implantation, of clinical pregnancy rate. And this meta-analysis is the same. They analyze the pregnancy rates and the live birth rates, and they, according to the application or not, this activation, they found the odds ratio 3.5 and 3.3 when they use this oocyte activation. Okay, and so far was a good result. But it's true that we saw that we could increase the results, the fertilization rates, the number of the pregnancy rates, the implantation rates. But we did it in a different cycles. Okay, the first cycles, the first attempt from the patient wasn't good, and then in the second, on the new attempt, we offered this activation, but it was a different cycle, different stimulation. So in the next study, we wanted to check in the same cycle with the previous problems in the fertilization rates or poor quality. So in the following cycle, we wanted to check if we could or not increase or increase the results. Okay, so we did it in the half of the oocytes with the conventional ICSI, on the other half with the activation. So we did it in cases with a poor quality. Okay, when the embryos were arrested or neither no Murria nor blastocyst on day 5 or less than 50% of blastocyst rates. And in that cases, we wanted to check if we could or not improve our result in the half of the cohort with this conventional ICSI or with activation. So in the first results, we wanted to check implantation, pregnancy, usable blastocyst, blastocyst, fertilization, but we wanted to take a look to this because usable blastocyst rates was the good blastocyst. Okay, and this is for the patients with problems in the quality of the embryo. So you can see that just 5% more of higher levels when we use this activation compared to conventional ICSI. So when we analyze the embryo quality, okay, so here we classify the embryos in a different letters A, B, C, D according to our biology society in Spain. So we classify in A, B, C, D, better quality and worse quality. And then you can see that with activation, we could increase the levels of the B embryos, so the good embryos, the best embryos. But when we group the embryos in a better embryos compared to the worst embryos, so you can see that we could increase the quality of the embryos in 10 points, the best embryos, using this activation compared to conventional ICSI. And according to the worst embryos, the same, lower levels of worst embryos when we use this activation. Okay, and when we separate this in the cycles with PGT cycles, okay, because poor quality, we included patients for PGT and patients with no PGT. So when we have separated and we have analyzed just the patient for PGT, we have seen similar results. Okay, the usable blastocyst rate was higher with activation compared to conventional ICSI. And the embryo quality, the same results, higher levels with activation with in favor to good embryos, and no differences because the sample of the size was lower than before. And in the cases, this is interesting group because it's a patient with no PGT with a poor quality. So probably they were patients, they were not young patients. So in this case, we analyzed all of them and we can see that the usable blastocyst rate was higher for the patients when we use, for the oocyte, sorry, when we use this activation. And the embryo quality, similar results. Okay, it's true that we reduce the population of the sample. And what about the fertilization failure? So in this case, we included just 23 patients, and you have to think that sometimes we have patients that is the last times, okay, and then in that cases we offer all oocytes for activation, and sometimes we just get a small number of the oocytes, 5 or 6 oocytes, and in that cases we offer or we perform this all the oocytes for activation. So the minimum criteria was 8 oocytes. With 8 or more, we did half of the oocyte for activation and the other half for conventional ICSI. In that cases, you can see that we got this result. Okay, so obviously, this is too high with conventional ICSI, and this is good levels, a little bit high, okay, 67 compared with 62, almost 62. So probably, so maybe we are over-indicated patients in that group, or maybe as the sample of the size of the population is not very high, these levels are too high, and maybe we are completing the study, and when we finish this study, these levels will reduce. We don't know. The embryo quality is not our goal in this group. Okay, as you can see that no difference is very similar, and we can conclude that with the oocyte activation works if the problem is the sperm. In cases with a poor embryo quality, we have seen a 10% or 10 points more of embryos with a good quality. So probably we can say that this activation works when the problem is the sperm for this indication. In cases with fertilization failure, you can find a difference literature that they say that yes, this activation work when the problem is the sperm for cases of fertilization failure or low levels. But in our case, we need more time to increase, because we think that we need to increase this size. And of course, we can say that the problem this activation doesn't work if the problem is the oocytes, because in that case, we probably have a problem in the maturity of the oocytes. In that case, we can use it to triggering to try to improve it. And let me just show you and share with you this interesting case that we have in our clinic. A couple with 38 years old and 60 and 36 years old men with 2 previous attempts cancelled by low response. And the first stimulation, we got just 2 metaphase 2, and we beatified them. And the second stimulation, we got 6 fresh oocytes, and we added the 2, and we thought these 2 beatified oocytes, in total 8 oocytes. And we just got 1 zygote, and finally we canceled the embryo transfer because the embryo was arrested. And the new strategy, we changed the female gametes, okay, and we offer an egg donation with 14 metaphases of the donor. And surprisingly, okay, to our surprise, we just got the same result, just 1 zygote. So we reached, or this embryo reached the blastocyst stage, and then we transferred the embryo, but the patient didn't get pregnant. And the new, so finally we realized that the problem was the sperm, and then we offered this activation with a new egg donation, because the patient didn't want do it with her own eggs, and we got this 41 fertilization rates, and then we transferred the embryos, and we froze the rest of the embryos, and finally we got a good result. So we have to offer the best for the patient, and sometimes it's not easy. Thank you very much.
I'm just wondering, as a question, have you tried to optimize your activation process? Because we've learned from the work of, Björn Hendricks, as you mentioned in your talk, that, time of exposure or multiple times of exposure or even the culture media can impact the level of oocyte activation or the successful fertilization rate and the blastulation rate in your studies. Have you thought about maybe changing your protocol a little? You had a very short time of oocyte activation exposure.
Yeah, well, your question is we have modified our protocol in a daily clinic for this kind of patient.
Yeah, have you thought about changing it just to optimize the protocol in your clinic?
Yeah. We do it. We do it. Okay, when we have a patient with previous cycles that fail, or when we got a less fertilization that we expected, we usually offer this activation. And if we have at least 8 oocytes, the half of the oocytes, we offer this activation. When we have a patient with a poor quality in a previous cycle, or in our clinic, after check that, okay, this patient we have a percentage of the blastocysts are very, very poor, or the quality because the quality is very, very poor. They finally the embryos are very fragmented and they arrest. So then we offer this option. So we have changed this way for this kind of patient, just in this kind of patient, fertilization failure, total fertilization failure, less than 30%, or when we have observed poor quality.
Okay, thank you. I think we need to move on and introduce the next speaker. Thank you very much, Alberto.
Okay, you're welcome.
Our next speaker is Lucia Murria Aguilar, who's a research embryologist specializing in oocyte vitrification and the identification of oocyte quality markers. And she's currently doing her PhD at the EV Foundation and at EVRMA Valencia, where she studies the effects of vitrification on oocyte and embryo preservation. And she's going to be talking today to us about using AI to evaluate oocyte quality. So welcome.
Thank you, Aisling, for this kind introduction, and thanks to the IT organizers for inviting me to this webinar. In this talk, I will introduce you an artificial intelligence tool to assess oocyte quality objectively. I work at IBRMA, so I don't have any financial interest in the tools that I'm discussing today. The oocyte plays an essential role in assisted reproduction treatments, and its quality is directly related to its success. Between 60% and 70% of the oocytes retrieved in ovarian stimulation cycles exhibit one or more abnormal morphological characteristics. The morphological alterations are described in the literature as a way to assess oocyte quality. But in this slide, I show you an example of how the ASEVIR Spanish guidelines classify these alterations mainly into 3 groups. The cytoplasmics, when we find vacuoles, smooth endoplasmic reticulum, necrotic bodies. The extracytoplasmic alterations, such as increased perivitellin space, debris in the perivitellin space, and polar body alterations, such as the presence of more of one polar body or an enlarged polar body, which is often associated with chromosomal abnormalities. So the thing is that despite this effort to classify all these alterations, there is no robust evidence linking these morphological characteristics with the real clinical outcomes. So historically, oocyte morphology was considered during embryo selection. Its evaluation has lost clinical relevance due to the lack of strong correlations with clinical success rates and the development and rise of automated embryo assessment tools. So nevertheless, the quality of the oocytes remains the most crucial factor for reproductive success, as it contributes not only with the chromosomes, but also with cytoplasmic organelles like mitochondria, which are essential for early embryo development. So this gap in standardized evaluation methods has driven the development of artificial intelligence tools for assessing the oocyte quality. The deep learning models can analyze images in fine detail, detecting patterns that are invisible to the human eye, even under the microscope. So using these artificial intelligence models can improve how we evaluate egg quality and can help address current challenges in assisted reproduction. So in this way, Future Fertility has developed two artificial intelligence-based tools, Magenta and Violet, to evaluate the oocyte quality using deep neural networks that have been trained with more than 100,000 images of oocytes and their known reproductive outcomes. So these tools, both tools, analyze 2D images of oocytes to predict their potential to develop into blastocyst, identifying success markers that may not be visible to even experienced embryologists. So Magenta, on the one hand, assess oocytes and provides a quality scores, and this allows for more informed decision-making in the IVF cycles and future treatment planning. And Violet, on the other hand, specializes in evaluating oocyte quality prior to vitrification. So it offers an objective view of the probability of successful blastocyst development, and it's particularly useful in guiding in egg freezing cycles. So in this presentation, I will just focus on Magenta, but I wanted to mention that Violet also plays a crucial role in assessing oocyte quality in the context of egg freezing. So yeah, Magenta is an artificial intelligence-based tool, as I said, that assesses the oocytes, and it gives them a score from 0 to 10, which is related to the probability of reaching the blastocyst stage. To assist with interpretations, the developers of this tool have created this reference table that outlines the probability of blastocyst formation for each score Magenta range. It is based on the data from oocytes of similar scores. So as expected, we observe a progressive increase in the blastocyst development rates as Magenta scores increase. So while this reference table is helpful, it's important for each clinic to analyze their own blastocyst rates because Magenta performance may vary depending on the specific patient population. So clinics should tailor their analysis to their own data. In this video, let me see if it works. Yeah. This video shows our user experience using Magenta. First, you have to enter the patient's data and the date of birth, because this artificial intelligence algorithm takes into account the oocyte age and the number of mature retrieved oocytes. So then, as you can see, you start taking the pictures with the camera connected to your laboratory microscope. In this case, we were taking the images before the ICSI procedure with the camera connected to our microinjection microscope, but you can also upload the images of the oocytes from the time-lapse systems like Getty or EmbryoScope. So as you can see, it's very easy and quick to take the images. Once you finish taking the pictures of the oocytes, you click on complete cycle and you upload, and then a report is generated on the online app. If you go to the online app, you can see all the pictures of the oocytes, and by clicking on Magenta report, you can see the results of the analysis. As I said, each oocyte will receive a score related to their probability of reaching the blastocyst stage. You can also download a report. This is how the report looks like in order to send them to your patients. And first, in the report, what you see is how the oocytes are distributed in the reference table that I mentioned before that Future Fertility has developed, in which they indicate the probability of blastocyst arrival for each range of Magenta scores. And then you can see the specific score of each of the oocytes. So we wanted to test how magenta performed in our lab. So we conducted a retrospective single center study at TBRMA Valencia. We included ICSI cycles without severe male factor, focusing on different populations, fresh and vitrified donor oocytes, as well as fresh and vitrified patient oocytes. So this table shows you our study distribution. We analyzed 211 ICSI cycles, 72 of fresh donor oocytes, 59 with vitrified donor oocytes, 64 with fresh patient oocytes, and just 6 with vitrified patient oocytes. So all oocytes were scored using the Magenta's artificial intelligence systems, which assigns a score, as I said, from 0 to 10 for each oocyte. And after ICSI, embryos were incubated until day 5 or 6 in time-lapse incubators, the EmbryoScope, EmbryoScope Plus, or Getty. All embryos were evaluated by senior embryologists according to the Xavier Spanish criteria. And additionally, the embryos cultured in the EmbryoScope Plus were also scored using the IDA score version 2 model, that is a deep learning model that automatically assigns a score for the embryos that is related to their probability of implantation. So the objective of our study was to analyze the correlation between magenta scores and fertilization rates, blastocyst rates, and blastocyst quality determined by both the conventional morphology and the artificial intelligence automated. And for some analysis, cycles with vitrified patient oocytes were excluded due to the small sample size of this population. In this slide, I show you the characteristics of our study population. As expected, we found that the donor oocytes were younger than the patient oocytes analyzed, and the recipient's age was higher in the donor group compared to the patient groups. We also found differences in the male age between the two groups. There was a higher number of oocytes and major oocytes retrieved in the donor group, but the maturation rate of these oocytes was comparable between the two populations. Here you can see a descriptive analysis of the distribution of the oocytes across the different magenta scoring groups. We observe a higher proportion of embryos in the second lowest magenta score group among patients compared to donors. And in contrast, donors have a higher proportion of oocytes in the highest magenta score group, the highest quality ones, compared to the patients. When we analyze whether there was a difference in the proportion of embryos in each severe group between the two populations, we saw that there was a higher proportion of the medium quality embryos in the donor group compared to the patients. However, when we analyze the distribution of embryos across the IDA score groups, we observed that donors that had a significantly higher proportion of embryos in the top quality group and a lower proportion of embryos in the second lowest score group. So this pattern aligns with the results seen in the oocyte analysis. So first, although magenta was not designed to predict oocyte fertilizations, when we analyzed all oocyte populations, patient and donor oocytes together, we observed that magenta assigned different oocyte scores to those that fertilized compared to those that did not. The ones that fertilized received an average score of 6.08, and the ones that did not received a score of 5.35. We also analyzed the fertilization rates of the oocytes across the different magenta score groups, and we observed a stepwise increase. The fertilization rate of groups 2, 3, and 4 was statistically higher compared to the first group. And additionally, the fertilization rate of group 4 was significantly higher than that of the second group. Then we analyzed magenta predictions separately among the different populations. This analysis shows similar results to the previous slide where all populations was combined. So as you can see in the table, when we analyze patient and donors separately, magenta still assign higher score to the oocytes that successfully fertilized compared to those that did not. although magenta was not built to predict fertilization. Additionally, we analyzed the fertilization rate across the different magenta score groups for fresh patient oocytes, fresh donor oocytes, and vitrified donor oocytes. And in all three groups, we observed a stepwise increase in fertilization rate as magenta scores improved. Specifically, in patient oocytes and fresh donor oocytes, we observed a significantly higher fertilization rates in the highest magenta quality groups compared to the lowest one. In the fresh donor oocytes, no significant difference was observed between the groups, but this is likely because most of these oocytes are expected to fertilize as they generally have higher quality, which is also reflected in our results. We observe really high fertilization rates across the different scoring groups. We perform a multivariable logistic regression, including all the confounding factors that I showed you in the left side of the slides, to evaluate how well magenta can predict fertilization. Although magenta, as I said, was not built to predict fertilization, for patient and donor oocytes, the magenta score remained a significant predictor for fertilization with an odds ratio of 1.18 and 1.716 respectively. We use the predicted probabilities of the model to create ROC curves and calculate the area under the curve. And as you can see, we obtain an area under the curve of 0.604 for patients and 0.577 for donor oocytes. To analyze the performance of the model in predicting the blastocyst development, we analyzed again all oocytes populations together, the patient and the donor ones. And we observed that magenta again assigned different oocyte scores to those that reached the blastocyst stage compared to those that did not. The ones that reached the blastocyst stage received an average score of 6.39, and the ones that did not received a score of 5.58. We also analyzed the blastocyst rate of the oocytes across the different magenta score groups. So on the left, I show you the reference blastocyst rates of fetal fertility. And on the right, you can see our real blastocyst rates in its scoring groups. As you can see, the blastocyst rate of groups 2, 3, and 4 was statistically higher compared to the first group. Additionally, the blastocyst rate of group 3 was statistically higher than the one of the group 2. So again, when we analyze magenta predictions separately among different populations, the results were consistent with the combined analysis from the previous slide. As shown in the table, when patient and donor oocytes were analyzed separately, magenta continued to assign significantly higher scores to oocytes that successfully developed into usable blastocysts compared to those that did not. Additionally, again, we analyzed the blastocyst rate across different magenta score groups for fresh patient oocytes, fresh donor oocytes, and vitrified donor oocytes. In all three groups, we observed a stepwise increase in blastocyst rate as magenta scores improved. Specifically, the lowest scoring group in its population had significantly higher blastocyst rates compared to the higher scoring groups, and the highest scoring group saw a statistically significant improvement over the mid-range groups. This trend was observed even in the fresh donor oocytes, where most of the oocytes were of good quality, further highlighting the predictive power of magenta. This slide presents the results of the logistic regression analysis for the prediction of the blastocyst formation. The analysis was adjusted again for the factors I display on the left of the slide. So we performed this analysis in 4 different cases. First, considering all patient populations together, the donor and the patients. Second, focusing only on fresh patient oocytes. Third, analyzing fresh donor oocytes. And finally, looking at vitrified donor oocytes. In all of these models, magenta remained a significant predictor of blastocyst formation, demonstrating its robustness across different oocyte populations. The predictive probabilities of the models were used again to create ROC curves and calculate the area under the curve for each one. So the area under the curve for all populations combined was 0.630. For fresh patient oocytes, we obtain an area under the curve of 644, 0.573 for fresh donor oocytes, and 0.625 for petrified donor oocytes. Finally, we assess the relationship between magenta scores and embryo quality determined by both the artificial intelligence automated with the IDA score version 2 and the conventional morphology with the Xavier classification. In this case, we divided the oocytes scores into 3 groups since, as observed earlier, the lowest scoring oocytes do not typically reach the blastocyst stage. So looking at the Xavier classification, the table on the left, we did not find any significant differences in the proportions of embryos classified as A, B, or C across the magenta score groups. However, when we examine all populations combined and use the IDA score to assess the embryo quality, we observed a significant difference. Embryos from the highest magenta scoring group had significantly higher average IDA score compared to those in the lowest scoring group. While no differences were found in the Xavier classification, the positive correlation with the IDA score emphasized the precision of the artificial intelligence tools like Magenta or the IDA score. So additionally, when we analyze the Pearson correlation between Magenta scores and the IDA score for all populations combined, we found a statistically significant positive correlation. And when analyzing each population separately, the fresh patient oocytes, the fresh donor oocytes, and vitrified donor oocytes, we did not see statistically significant differences, but in each population, embryos originating from the highest scoring oocyte in magenta had a higher average IDA score. So to summarize, we've drawn several important conclusions with this study. First, that even though magenta was not originally designed to predict fertilization, it has consistently given higher scores to the oocytes that successfully fertilized compared to those that didn't. Furthermore, when we looked at the fertilization rates across different magenta score groups, we saw a clear stepwise increase in fertilization as the scores improved. This was consistent across all populations, and the predictive power was reflected in the areas under the curve values. So all that suggests that magenta has significant potential for predicting the fertilization outcomes. Next, when we analyzed the blastocyst rate, we found that magenta could also distinguish between oocytes that reached the blastocyst stage and those that did not. We observed an increase in blastocyst formation rates, and magenta scores improved, both when analyzing all populations together and when looking at individual groups such as the fresh patient oocytes and donor oocytes. And the area under the curve values support this finding, further confirming the robustness of magenta across the different populations. And finally, regarding the embryo quality, we did not find a significant association between magenta scores and the embryo quality as assessed by Xavier criteria. However, we did observe a positive correlation between magenta scores and the IDA score, highlighting the value of the artificial intelligence tools to provide more precise and objective assessments of embryo potential, which conventional methods may not fully capture. So I would like to end my presentation highlighting the key takeaways from this study. So first, we have demonstrated the effectiveness of magenta as a strong predictor of key reproductive outcomes, including fertilization, blastocyst formation, and embryo quality. The artificial intelligence opens up incredible opportunities for analyzing variables like oocyte quality, which have been difficult to evaluate successfully until now. And using artificial intelligence to assess oocyte quality could enable more timely and accurate thawing of the oocytes, help identify reasons for previous treatment failures, and offer more personalized patient counseling. So in summary, artificial intelligence powered tools represent a new frontier in reproductive medicine, allowing for more precise and individualized treatment strategies that could significantly improve clinical outcomes. Finally, I would like to thank you for attending to this webinar and also the IVF laboratory of IVI Valencia, my team, my supervisors, Ana Cobo and Marcos Meseguer, who is today here, and of course the organizers of this webinar. Thank you.
Thanks, Lucia. That was an amazing presentation. I, of course, very much am interested in what you're studying as it relates directly to future fertility. You're utilizing our tools. Evie, also with our collaboration recently, you're integrating Violet into all of your labs for your egg freezing patients. Your research here really focuses on magenta, though. And I'm just curious, with all of your magenta research, what is your personal opinion of what magenta might bring, what sort of value might it bring to the IVF patient or egg donors, or what is your view on that and how that might be utilized?
Well, I think that magenta can help a lot to the personalized counseling of the patients. It can help, especially in my opinion, to the patients that have some failure and you don't know why. As Alberto said, we have some of them. So you can just take the pictures that you have available if you have the time-lapse systems and just review what happened with these oocytes, how were they assessed. So this is so useful. And also in the vitrification program of the donor ones, who maybe you have more time. If you evaluate the oocytes just after warming, you can assess them and make the decision to thaw more if you think it's necessary, or you have more time and more to make more informed and objective decisions with all these patients.
Wonderful. Thank you so much, Lucia. I'm going to open up the floor for all Q&A for all of our presenters today. So I'll let someone else ask a question and we'll keep, sort of passing through the questions as quickly as we can.
Thank you very much, Jullin. I mean, we have a lot of questions in the audience. I would like to take the opportunity to ask a question to Lucia, because even is also one of my PhD students. She has done a very good presentation. She has a very good English. It looks like the new generation of Spanish speak better than ours, and she's doing very well. And I just to make a little bit more practical, because you have been talking about magenta and a little bit about violet. Which is the difference between these two tools that we have in the lab? I mean, it has been sometimes complicated for the embryologist. I mean, we have been introducing the technology in most of the clinics of the group, and then the questions comes trying to understand which is the real difference. I mean, why we should use one or another one, and which are the benefits of using one or another tool. Lucia.
Well, Violet is just focused on the fertility preservation, not fertility preservation, sorry, the egg freezing program. It is designed to assess the oocyte prior to the vitrification, so it takes into account the vitrification process, and it gives you a probability of reaching the blastocyst stage for these oocytes. So it's very useful just for the fertility preservation patients and for the organization of the donation program in some clinics that vitrify and send them to other clinics. So this is what's Violet designed for. And magenta, it's designed for the assessment of the oocytes prior to the ICSI, just after thawing or just prior to the ICSI, so you can just help allow the personalized counseling of the patients and the personalized, you can see how their other cycles work. You can compare it to the new cycles, what's the quality of the eggs. So it's quite useful in the ICSI cycles. I don't know, Jullin, maybe you can give some points.
No, that's fantastic.
Thank you. Okay, I was wondering, we have a question here from Michael Reed for Alberto. He's asking a very interesting question, asking if you have any experience with vitrified warmed oocytes and using calcium activation on vitrified warmed oocytes, and the effect maybe of the vitrification on the post-warming calcium oscillations.
Okay, well, we don't know. We don't have experience. So comparing the vitrified oocytes and fresh oocytes, But from my point of view, I don't think so that the vitrification technique affects to the levels of the calcium increasing or decreasing these levels, because the levels of this calcium is depend on the spur. So probably this vitrification or technique or without the oocytes don't affect to the levels. It's my opinion. But we don't know. We don't have experience.
Okay, thank you.
Okay, well.
I have a question here for Dr. Xavier from Amy Cohen, and she asks, when would you perform the rescue ICSI, and would you do this on any oocyte that only has a single polar body, or would you not do the rescue ICSI if you overall had really good fertilization?
Thank you very much. That is a really good question. I think from now on, the evidence requests that you could do early rescue ICSI after 6 hours post-insemination, and especially for patients that have more than 70% of oocyte with only one polar body. However, in the near future, I think we would be able to do it for any oocyte that doesn't present the first polar body, especially if we find new markers, more cytoplasmic markers, not the polar bodies, but cytoplasmic waves, maybe a membrane movement. And I think in the near future, with 3 images of time-lapse, very short time, we could detect the ones that are fertilized, but only with one polar body, and differentiate them from the ones that are actually not fertilized.
So would you say that you need 100% time lapse to really do this well, to be able to do the short inseminations?
No, I don't think so. If you look at 6 hours, you definitely can inject oocytes that have only one polar body. You don't need the time lapse, but I think the time lapse gives you a lot of confidence, a lot of experience, and your eye is getting, used to oocytes that are fertilized, and you can better choose. But I think we need more markers for this.
Amazing, thank you.
Well, there is a very good question that we have discussed, Lucia and myself, many times, from Michelle Skiv from USA. And she's asking, and we have discussed this, about the correlation between what we believe is a bad morphology and the score. I mean, Lucia, we have been talking many times about this in our research conversations. What is your opinion or your feeling or your knowledge about the relationship or not between the classical oocyte morphology and these scores from the magenta?
So we have looked at it and we are working on that because we are like trying to evaluate all the oocytes manually, but see like the alterations that they have and what's the correlation with the artificial intelligence algorithm score. And we are not finding like really quite strong correlations of them. We sometimes when you see like a horrible, let's to call them in a way, oocyte with a lot of morphological alterations, they usually do not have like a very high artificial intelligence score. But sometimes, I mean, the ones that have really bad morphology usually have very bad scores, but sometimes you get surprised because some of them do not have really bad score and they actually fertilize and arrive to the blastocyst stage. And even in the other way, it happens too, like the ones that have very good morphology, you see them and you think that they are very good oocytes. Then when you analyze them with the artificial intelligence score, you may think that it's wrong because it doesn't have like a very good score, but then you realize that the outcomes are not really well. So there's not a strong correlation between them. We actually found like some patterns, but actually the artificial intelligence sees some things that we can't actually see. So that is why this is useful.
That's definitely research that Future Fertility has been trying to do as well, and kind of why we, developed this tool in the first place is because as an embryologist, I've definitely seen eggs that are not so pretty turn into beautiful embryos and vice versa. So we do have, research on that, and I think that's why there isn't an egg scoring system that's used in clinical practice, because there's just not enough dysmorphisms or enough that embryologists can see within the oocyte that correlates with the outcome. So I think it's really been difficult to create sort of a manual scoring system for oocytes like we do have for blastocysts and even sperm morphology. I have a question here, and I think it's for Dr. Alberto. What would you say is the optimal time for calcium ionophore exposure after ICSI? If you have a ICSI that's really difficult and takes a long time, 30 to 40 minutes, should they split the oocytes into groups if they're going to do activation? Do you have any comments or suggestions? And this is for Julia. Oh, sorry, you're on mute, Dr. Alberto.
Can you hear me right now? Okay. No matter if your ICSI, your case is a difficult ICSI and you need more time to do it, so you have to expose the oocyte after injecting them for 15 minutes in these drops of calcium, for 15 minutes, and after that you could put them into a culture dish. So it doesn't depend on your ICSI is difficult and you need more time to do it or not. So it doesn't matter.
Okay, so as soon as you're done your ICSI, you can do the calcium activation.
Okay.
Can I have a question for Lucia that I see here in the audience. Amy Cohen is asking, will you be looking at clinical outcomes with your magenta and your violet scores to see, because has it changed the number of oocytes that you're actually using in your practice, in your donor program, or recommending patients and how many oocytes they should cryopreserved? So, which would probably be important to know about the clinical outcomes of these oocytes, not just blastocyst rate.
Yes, of course. I mean, our next step in our study is seeing the clinical outcomes. We want to increase a little bit more the sample size of our study, but of course, the important thing here is the clinical outcome, how it relates to implantation. It looks like it will relate, but I cannot say it like too loud. I want to increase the sample size, but yeah, it's amazing.
You're just giving a sneak peek of the results, maybe.
Well, we have a lot of questions, but we will try to summarize a little bit. But there is one from Netherlands, from Elke. Or Elke, I don't know if I'm doing well. Is there any difference between 1 3-hour short insemination and 4-6 short insemination? I mean, the point is, it feels safer to do 4-6 hours, and then I add to that question. What about the logistics, Xavier? The logistics, because just thinking in the times of the embryologist, and I remember so many times in talking with embryologists in France, no, we have our day work is 7 hours. You have your duration of the work every day is 7 hours. So how you are gonna be able to adjust, or if, I mean, of course you can do shifts, but this could be logistically a problematic, right?
Well, it can be problematic. Okay, to answer the first question, the difficulty when you do 3 hours short co-incubation is that sometimes the cumulus is not dispersed enough, So we like to wait a little bit more. That's why we chose at least 4 hours, between 4 and 6 hours. The between 4 and 6 hours, to answer your question, Marcos, is because I don't do 7 hours per day. It's more like 8, 9. So what happens is that I have consultation in the afternoon after the ICSIs and the lab work. And between the consultation or after the consultation, my colleague or I, we go in the lab and we do the denudation. We actually do everything at that time. The other embryologists are gone, of course. So yeah, the logistic is a bit difficult. And so also if you want to do early rescue ICSI, you have to prepare a dish and you have to warm the dish. So what would you do? Do you do it in advance and lose a little bit of money, or do you do it and you will need 1 hour? I think it's good that you denude around 4 to 5 hours, because if you see a real issue, which is like all oocyte with only one PB at 4 hours, there is a real issue. Okay, so you do prepare your dish and you will do the ICSI maybe 1.5 hours later, and you will have a chance during the ICSI to check the oocyte before injecting. So that's the logistic, and we are talking getting out of the lab maybe before 6 p.m. So for me, it's good, but I understand that in some cases it's not good because of people have to get out of the lab early, of course.
There's a question here from Bronx Stone. It's for Lucia, but I think I might be better able to address it. It asks from what data sets are the AI algorithms generated and updated? So this is regarding the future fertility violet and magenta. For information, it is the same model for those two different tools. The AI is built off of data from more than 150,000 oocyte images and the reproductive outcomes. Additionally, currently this comes from more than 13 clinics or clinic networks from 9 countries around the world. So it does try to be very diverse. And we're constantly, continuing to gather more data to ensure that we have global representation within our data sets, constantly trying to sort of update the model as well, but this is versioned. So the data or the AI itself doesn't just take in the data, learn from it, and spit out sort of a new prediction. We want to make sure that always those predictions are very well controlled and are adding value to the results and in a positive way, so that we ensure that our correlations and our predictions to blastocyst development are still there and going in the right direction that we expect. So lots of data, great diversity, and always willing to add more data to that to ensure diversity of a global population so that it can be utilized in different clinics around the world. And we are in more than 25 countries. So just a quick sort of comment on that, and I'll pass off. Maybe we have a couple more questions each, and then I think we're about ready to wrap it up.
Yeah, I think we have here one for Dr. Alberto from Helen from Moldova. She wants to know a little bit more about the patient selection criteria, and what do you think is really the most critical factors when deciding about applying the oocyte activation? And do you think that AI might be able to help you in selecting these patients in the future?
Okay, so the candidates to offer this technique.
Yes.
Well,
which would be the most prominent group for your clinic, maybe your clinical experience?
Yeah, well, as I explained to you before, so we recommend this activate for the patients with a previous fertilization failures of less than 30%. In cases with a poor quality, when we have observed a poor percentage of blastocyst rates, less than 15%, or neither morula nor blastocyst on day 5, or when we have all embryos arrested, then we offer. And even in cases when the spur has a terrible morphology, with the morphology is very, very altered, so in that cases, we recommend this technique, this activation.
So you would recommend this before moving forward, maybe with oocyte donation, or to improve?
Well,
is it patients that are?
Yeah, well, and in my presentation, I showed you that case that when we offer to this couple an egg donation and finally didn't work because the problem was the spur. So in egg donation, if the problem is the spur, we can get a fertilization failure or maybe a poor fertilization rate. So in that case, it's not very common that you offer egg donation and then the problem is the spur, but maybe can be.
Thank you.
Okay.
Maybe one quick question and we'll wrap it up. I have one for Dr. Xavier. From your experience, do you think the interval between finishing the final sperm prep and the actual short insemination, do you think that can affect the fertilization rate if the timing's too long?
Well, in my lab, it's never more than 4 hours. We do the preparation between 8 and 9 a.m. and we do the insemination between 11 and 12 for just logistic reasons, because we have to, of course, get the male into the sperm collection room and everything. And I think there was only one paper showing classical IVF that too short timing or less than 1 hour or more than 4 hours could be detrimental for fertilization rates. But in my knowledge right now, to the best of my knowledge, there is only one paper about that. There are many papers for IUI, even ICSI, but not for classical IVF.
Great, thank you so much. I think that's it for time regarding questions. So I think we can wrap up this wonderful I3 center. And Marcos, I'm just trying to see if your Wi-Fi is working there. You might be cutting out. All right, guys, I'm gonna help us wrap up here because I don't think Marcos's Wi-Fi is behaving, but we would like to thank everyone who took part in this webinar. Our co-hosts, Dr. Aisling and Dr. Marcos, as well as the presenters, Dr. Xavier, Dr. Alberto, and Lucia. And thanks to Future Fertility for kindly sponsoring this enlightening webinar. And I would also like to not forget the amazing I3 team from the organizing committee. They are really the initiative behind these presentations that are so well attended. They are Jacques Cohen, Peter Nege, Marianne Civitas, Thomas Elliott, Fran Farley, Violetta Sura, and Giles Palmer.
And yes, and thanks to everyone that joined us today. And we hope you will join us for the next session of the I3 session, and it will be on the 15th of October. And it will be about clinic and laboratory time savings. So it's called About Time Too. So it's all about being efficient. So please register and join us in the next session.
Thank you, everyone.
Thank you. Bye, everyone.
Bye-bye.
Bye.
Bye-bye.